Hello, this is Ort-Patrick. I'm a student with the PA College of Health Sciences. This is IPC 502, Technology and Innovation. And I'm going to be doing a presentation on ED overcrowding. What is ED overcrowding? It is defined as a situation in which the ED function is impeded primarily because of the excessive number of patients waiting to be seen, undergoing assessment and treatment, or waiting for departure compared to the physical or staffing capacity of the ED. Causes of ED overcrowding. Looking at this conceptual model, you can see that there is input, throughput, and output. Input is your patients that are presenting to the waiting room, patients that are referred from the primary care physician office or urgent care centers for a higher level of care. This also includes the patients arriving by ambulance. Throughput is the actual processes of the ED, your triage, your diagnosis, and your treatment. Output is your patients that left without being seen, left against medical advice, patients that are discharged, patients that are admitted, and patients that are transferred. When any one of these three becomes overloaded, it creates a domino effect. So if you have 12 patients waiting for beds, inpatient beds, and there are no beds, your waiting room is going to start backing up eventually, which then is going to affect your triage. Again, if you have a high influx of ambulance patients or walk-in patients, it's going to overload your triage processes. So it's a cascading effect. Now we're going to look at some implications of overcrowded. Ambulance diversions. This is when 911 is notified that the ED is on diversion. EMS providers must inform the patient that the ED is extremely busy and there may be extended wait times, including waiting for an inpatient bed if they're admitted. Prolonged waits in the waiting room, which patients go without an assessment or treatment for a substantial amount of time. Delay in delivery of care. When you're in an overcrowded state, it increases the risk for medical errors. Communicable disease spread. You have the risk of having patients in the ED that may have a communicable disease such as meningitis or the flu, where they could easily pass that to another patient. And then you have staff burnout and dissatisfaction from the sheer number of patients. Some of the interventions at LGH to decrease overcrowding is they have a fast care unit which functions sort of like a PCP office. They see minor illnesses and injuries such as lacerations, eye injuries, migraines, sprains, strains, and some fractures. Dental pain. Our rapid treatment unit is a 5-room area that part of the criteria is the patient must be ambulatory. There are no beds in these rooms. They are examination chairs, and they see minor things such as rash, sore throat, ear pain, and their goal is to have them in and out of the ED within 20 to 30 minutes. Our observation unit is on 7 East, and eventually we'll be expanding to include 7 West also. We increased staffing levels and we overlapped our shifts. We put an urgent care in directly across from the emergency department in the downtown pavilion. We worked with the primary care offices to extend office hours, and some offices include weekends. And also some offices built in hours to see patients with acute conditions that they could be seen the same day rather than come to the ER. Full capacity protocols are protocols that are implemented more when the inpatient is having difficulty where they're at full capacity with beds and they need to get patients discharged, open up beds that are typically not open. Triage nurse protocols. Typically once patients are waiting at least an hour and a half, the triage nurses will start putting in order sets specific to complaints, chest pain, CVA, abdominal pain, so that at least the laboratory studies and imaging exams can get started while the patient's still in the waiting room. And then we also put in a second charge nurse who basically just does output of the ED, such as discharges, facilitates inpatient admissions, and transfers out of the ED. My proposal to the ED leadership is to create an EPIC scoring tool. Currently, the tool that is most widely used is the National Emergency Department Overcrowding Score, NEDOCS, which is a real-time warning system for predicting overcrowding. The data must be manually entered by ED staff. It's a third-party vendor, and the initial cost is approximately $25,000 with yearly maintenance fees. This is an example of the NEDOCS calculator. These are screenshots from 3 different organizations. They're basically the same, where the ED staff would have to enter in this information manually and then get a result. Here's an example where the scoring is at the bottom here, and it corresponds to different colors. So for instance, this one, if the score was 120, the patient would be, the emergency department would be in an overcrowded state. So the benefits of building a scoring tool in EPIC is there's no cost other than time to build it in EPIC. The data is already in EPIC and constantly being updated. The score would automatically calculate, and it could populate to a dashboard which the ED already uses, and reports could be generated to be able to look back on any given day and time to see what the score was during that time frame. This is an example of what it would look like in EPIC. I built this in our playground. Currently I have this running at every 5 minutes just for testing purposes. So if you look at the score here, it's 3.8. If you would right click on it, you would see your thresholds here. So obviously 0 to 100 would be normal operating scores. And then as they increase, the color would change also. And these are indicators that staff would see, and to start taking action before they become to an overcrowded situation. ED leadership and hospital operations would have to develop surge plans. Surge plans are basically protocols outlining the steps that they would take when they are in different overcrowding situations. For instance, this one is in a dangerously overcrowded, which is indicated by orange, and a surge plan defines all the steps from the different areas within the hospital. Here would be your CMO, your CNO, department chairs, attending physicians, nurse analysts, charge nurses, and it's all steps and actions that they put into place, hopefully to relieve the ED from some of that overcrowding and get it back to a safe level of patients. I've also included my elevator pitch and my framework for innovation. And I thank you for taking the time to review my presentation. Have a great day.